quite a cold, chilly morning.
Yeah.
Yeah, thank God for Zoom. We can be indoors and, work. The reason why I called for this installment on pediatric surgery is because many people don't know how to handle the situation of their child going for surgery. It's a scary process, not only for the child who is being operated, but also for the parents, the caregivers, the caretakers. So I wanted to talk to people who have gone through the procedure with their children. Daktari, perhaps you can just, in a nutshell, take us through the procedure or the tools you give your patients and their guardians or their parents, and whether you divide the advice into age groups, because kids are of different age groups.
Okay. Thank you. I think the first thing that needs to be clear is for us as surgeons, it starts from where we even see these children. Before you even start seeing a child, you have to check whether the environment that you're using is appropriate for that age or even for children. So that if you're seeing a mother with a neonate, a child who is less than a month, or 1 year, then you need an environment which the room temperature is able to facilitate the exposure of that patient for examination. If they are big children, then what are the colors, even in the room that you're using? What is the decor like? I think Apodi said she's a homemaker like that. What is the decor? Is it friendly to children? Is it so dark? Some people just put black paints on walls. And what is the color there? And the drawings, is it in sync with them? Then some places we even put toys, we put cars there, we have balloons, and we even give them presents. We just try to connect fast. So I think even yourself, I think for pediatric surgeons, we really try to avoid wearing the white coat, because most of these children we see, they will already have had their vaccinations. And during the vaccinations, most of what they remember is the pain from the pricks. They also remember children who watch TV, and there are these programs on hospitals. They see how accident victims are being brought there, and doctors are wearing gloves. Some of them are about theater, and since they cannot connect fully with what is happening, they are scared even before they see us. But I think for us, through the training, the first thing we do, as I said before, is you have to be calm. You are calm and you have to speak to the child. Remember, every child, even the ones who are less than 1 year, they might not understand what you are saying. But if you're speaking to an infant, even 7 months, and they can see you, the way you present yourself, the calmness, and you are talking to them, you are maintaining eye contact. And of course, there's also contact to the skin. You can rub their hands or their hand, of course, ensuring that you are maintaining the COVID protocols as of now, so that once they say you are calm and you're actually connecting to them, even if they can't understand, that is the beginning. It also calms the parent down. Remember, for us, we deal with the two patients, the one who is actually sick, and perhaps the mother or the father who is sicker mentally than the child who you actually see. Most of the times, even what you're dealing with is something just for reassurance, but the anxiety from the parents is just too much. And children, especially those who are less than 1 year, they can't understand what is being discussed. They pick the anxiety from the mother. And if they see the mother is anxious, definitely that's a patient who will have difficulties first reassuring and even come to examine. So those two patients, basically the child and the mother, first have to be comfortable before you even start having a conversation with them. And the first thing is to let them first talk. Let the parents talk, listen to them, so that you can be able to gauge them to understand what level of anxiety or even understanding of the pathology of the disease that child has. And once their parents who will come straight, they have been exposed to what the child does and they have read. Currently, the goodness is you can read various materials. You can read Mr. Google, who unfortunately a number of times can give you wrong information. But most of the parents now also know their papers. So they have actually read medical journals, they have done research, and they actually have quality information about the disease that their children have. So once you have gauged that, that is the time now you decide on how you are going to approach it. If you have a child who is more than 7 years, the current standards is that they should be involved in the decision making. And the decision making here is the consent. They can't say no, of course, if there's a surgery to be done, but you must come up with a way for them to understand what is being done and the fact that it's for their own benefit. That one has to be established first. So always examine and talk to the children when their parents or guardians are around.
Okay.
The parents and guardians must always be around before you start. And that's why we allow the parents in the wards up to certain age, like up to 12 years and up to 15, depending on the comfort of the child themselves. So the parents, you have to first check on their understanding. Once you establish how much they understand the disease, take them through. The best we do is first to categorize the diseases. Is it a terminal illness? Some of the times we receive children from maternity or labor ward who have been born as pediatric surgeons, and the defects they have been born with, what we call congenital anomalies, are incompatible with life. Still, you have to remain calm. The child is there, the neonate is there, the parent is there. How you approach this one, or whether you need other people with you as you talk to those parents or guardians, is different from, for example, when you're talking to somebody who has just come for reassurance of colic pains, or an umbilical hernia, or an inguinal hernia. The same way with children who are born without an anal opening. And there's a big chunk of them that we, a big number, sorry, that we see at Kenyatta National Hospital as referrals. There's no anus, the abdomens are distended like that. So children, parents also have different levels of anxiety depending on the pathology that they have. So we explain first the disease. And we have to take time. Most parents are not medics, so we have to get a language that they can understand. The best, nowadays, there are fonts. You can always get images from Google, then you go to images. If they are available in the offices that you are in, try to explain in simple terms what problem they have first. Then number two, what are the issues? What are the complications with the disease? What would happen if you gave no treatment? And what treatments are available? Is there any treatment? Like, for example, if you get a child with cancer, is there a treatment for that illness? And if it is there, what are the chances like that? So I think in a nutshell is you first have to have the parent understand the disease. If the children are old enough, they also have to understand first. I don't know whether there are questions up to the consent taking.
I don't have any question. Perhaps Aponi,
Yeah.
do you have any question
Yeah,
for
no,
him?
I just, no, I'm just, I'm awed, Dr. Mwirisha, by the way that you have expounded that in a language that I'm able to understand as a layperson.
Okay.
It's very clear. And a few things that I find notable is, for instance, you said if the child has a condition that is incompatible with life, you use those words. Yeah,
Yes.
and yeah, I mean, that's a big one, huh?
Yeah.
Something
It
either
is.
this child, I mean, it's a way of saying this child is not going to live, or that something must be done to make this child compatible with life. Yeah, so I found that notable. Another thing that I find notable is the child who is age 7 and above is part of the conversation. Yeah, and will need to be encouraged to make a consent. Yeah, yeah. And that the parents are allowed to be with them in hospital.
Yes.
Until age 15. Yeah,
Yes.
I like it.
Okay.
Yeah.
Thank you. So a number of times, the extremes actually of incompatible diseases with life is, we see quite a number. These are the few that most of it is not written. And even the parents, after the terminal thing happens, they don't share a lot. This is what most likely you are not going to see on social media, but almost in every week, neonates are born with the multiple system defects, heart conditions which are inoperable anywhere. And some of them even combine multiple systems. You can have a child who is born with the heart completely open, and what is just covering is just the skin. We have quite a number of children who are born with the abdomen open. The intestines are not covered by anything. They're actually out there. You can have one, like the way I said, you have no anus, you have one kidney, and even the other kidney is not working. And even the treatment would mean replacing more than 1 to 5 organs, and some of it is not compatible with life. Now, for such parents, definitely, you're almost telling them, yes, your neonate is alive now, but the situation is going to change with the developing hours, perhaps even within the first day of birth, within the same day. And you have to arrive to that decision. Definitely, there are 5 stages of grief, but as we are in the first stage, where we have to notify, to explain to them perhaps what happened, because most of the people, closure is the most important thing. And a parent might not get closure if they haven't been told why it happened. Like, why would a neonate be born with the intestines out? Why would a child be born with the heart not covered within the chest cavity, with just the heart beating outside there? And in Kenyatta, we have had several Siamese twins, the ones who are joined. I think the most famous one is the one we separated. You remember the 2 girls we separated?
Yes.
We have had others after, and several of them, but those ones you'll never hear of them, because some of them, the way they are joined, the malformations are so bad that you even receive with one of the neonates dead, the other one is alive. And even if you are to separate the fused neonates, the other one doesn't. We have actually had several separations, but whatever is joined, there are 2 children sharing one heart, or 2 children with everything below the neck being one with the 2 hands. Those are difficult ones. So most of these ones won't bring TVs or the other things. We usually don't document. But then, how do we convey that incompatibility of life to these parents? I think from what I have seen, having worked in this situation, is, and to give this parent closure, is to take them back to how a human being is formed. After the fertilizations, especially after the first 3 weeks, that is the time where different systems start getting formed. The heart system and the blood vessels, the limbs, that is the upper hands and the lower legs, the head and the rest. In simple ones, you have to explain to them whether the intestines are usually outside, and then we have to have the wall forming over them, whether the heart is usually on the outside, and you have to have the chest cage forming over them. So in simple terms, we have to explain the stages of how a human being is formed. Sometimes we have pictures, there are drawings, there are books. Even in Google, we have those different stages. Then we have to tell them what could have gone wrong so that the process of forming that child did not complete. Then the most asked question is, what did I do wrong to have these issues occurring? Is it that I took medications? Is it that I didn't eat certain foods? Is it that it's within our family? All those questions. So we have to actually disclose. Some of them are just genetic coding. The rest are, they are familiar. If it's Down syndrome and those things, you know, these are genes passed from one generation to the rest. And they can definitely lead to those multiple things. So once we are, even if it is family, even if it's the drugs the mother took that has caused that anomaly, so long as you explain it nicely and they can remember they actually took some drugs, they were sick and they definitely needed treatment. So they needed that drug anyway for their own survival. Once you can give them a reason why it happened, then closure is quick and you're actually likely to get some form of agreement on how to proceed after that. Because once they understand, then you can now disclose how long are you going to have that unit? What is their role as you wait for the unit perhaps to succumb? Because that is definitely what is going to happen. That one you have to complete. But let's talk about the nice ones. The nice ones who have small defects and just simple surgery and they are over and they're happy. So those ones, the first thing is there is no small disease to a parent. Most of the parents, especially for something you're going to take a child to theater, even if it's for circumcision, there's nothing small. But then they have to understand what circumcision is. Actually, when we train the surgeons, we tell them that they must explain to the mother what they are going to do to the extent that the mother feels like they can go in there and do the same thing and come out with the baby. So that as you're operating and they're in the ward waiting for you to finish, they can almost tell the stages, where have you reached? If it is possible for you to even disclose how long each of those stages take, the better for the parent. And if you anticipate some delays in those stages, then you're also supposed to disclose. Like if you're going for a 10-minute surgery, just tell them, like for us surgeons, the most important person that needs to be told to the parents is the anesthetist, the one who makes the baby sleep. Tell them from the beginning, my work is to operate, but I'm going to give my anesthetist time. And time doesn't mean the drug they are giving doesn't work. Even the anesthetist has to play with the baby, give them the balloon with the gas until everything is done completely. Then you tell them, me when I start, this is where I'm going to cut, so you have to mark. Even currently the WHO standards is you mark with the child or you mark with the guardian. Like for example, if you're going to do an umbilical hernia, tell the mother this is the extent of my incision. So you take a pen, there's what you call skin markers, and you mark together. Even the child, most of them nowadays, they already say, hii kitovu yangu inavimba. And children actually as young as 2 years, when you tell them you're going to make it look like if they have other siblings, like your brother or your sister, like yours is out, you're going to put it in, and this is where you are going to open, and most children explain. So you involve the parent like they are going to be part surgeons to it. Now, once that one is done, the team that is going to handle the child actually, sometimes in some hospitals who meet standards, they are also at least introduced to the parents. That this will be my anesthesiologist, this is the assistant, or these are the nurses who are going to be in theater during surgery. And these are the people who will still see you once we finish surgery. So the main thing here is the mother must feel like they are part of the surgical team. If they don't feel like they are part of the surgical team, you're going to have a problem because you are not the one going to stay with the child after you have operated. You cannot assess pain And you cannot come after every 8 hours to actually tell what is the intensity or the degree of pain in that child. It is the mother who has been with the child all throughout after surgery. So once the mother understands how deep your incision was, which of those procedures can cause pain, and how to monitor it, they must know how to monitor it. They become your assistants once you have removed the child from theater. So this is the standard, and this is what we all try to do. Of course, in KNH and the big hospitals, that one we are able to institute. I think unless there are specific things you want me to bring out, I'll stop there.